Okay, so we're going to continue with our penicillin series, with this episode talking about ampicillin and amoxicillin. But first, let's review our summary points from last time. 1. All beta-lactam antibiotics have a beta-lactam ring. 2. The beta-lactam ring binds to penicillin-binding proteins to lyse bacteria. 3. Penicillin G and V cover streps well, but do not cover staph aureus or gram-negatives, with some exceptions. And 4. Cloxacillin was made only for staph aureus. Great. So let's start talking about ampicillin and amox, and I'm going to start with the key learning points. 1. Like penicillin G and V, they cover streps well. 2. They have some extended gram-negative coverage over Pen G and V, including some strains of E. coli, H. flu, and Proteus mirabilis. 3. They do not cover most other gram-negatives. 4. They do not cover staph aureus. And 5, they are the best option for Enterococcus and Listeria. Okay, so let's take a look at why. So remember how I showed you the beta-lactams all have these R groups. So here is ampicillin and amoxicillin. And notice how they have this amino group here. So this makes it more hydrophilic. And a more hydrophilic molecule is allowed to pass through the outer gram-negative membrane easier, thereby accessing those penicillin-binding proteins. And that's why ampicillin and amoxicillin have some coverage against gram-negatives. It's that hydrophilic amino group that makes it all possible. So when I say some gram-negatives, we're still talking pretty limited. The gram-negatives that it covers that penicillin doesn't are some species of E. coli, Haemophilus influenza, and Proteus mirabilis. And so these are all really high-yield gram-negatives to cover, but it's really not that many. So ampicillin and amoxicillin are broader spectrum antibiotic than penicillin G or V, but it's still not considered broad spectrum for gram-negatives. And remember those rare exception gram-negatives that penicillin G and V covers? Well, amp and amox cover those too, except syphilis for some reason. Sneaky syphilis. Okay, pause. This next point is very important, so I want to look you straight in the eyes for it. If there's one thing I want you to take away from this teaching, it's this. Don't fall into the trap of linking infectious syndromes to antibiotics. Instead, I want you to link infectious syndromes to the different bugs and bacteria that you think might be involved in that particular host, and to choose your antibiotic based off of that. There's a big difference in those two approaches. Dear Santa, all I want for Christmas is for the residents to take this concept to heart. And also for one of those massage chairs from space that the residents have in their lounge. I'd like that too. Okay, so let's talk about clinical situations where you'd use amp and amox. You could use amp and amox for infections that you treat with penicillin G and V, which by and large means a lot of different strep infections. Easy gram-positives to cover. But in these situations, you generally want to narrow to penicillin for stewardship purposes. The main situations where you'll see amp and amox used is when you need a bit of extra gram-negative coverage that penicillin G and V can't offer you. The big example here would be community-acquired upper and lower respiratory tract infections like pneumonia, acute otitis media, and acute sinusitis. But remember, let's not just link infectious syndromes to antibiotics. Let's practice that new thinking process. What are the bugs that we think are going to be involved in this infectious syndrome? So that depends on your host and that host's unique exposures. But the first culprits we think about are the bugs that we know live in these tissues already that have pathogenic potential. Now remember, the lungs and the upper respiratory tract, including the sinuses, eustachian tube, the middle ear, these are all continuous spaces, and bacteria can travel freely among them. Streptococcus pneumoniae is a key colonizer of all of these tissues. So that's the first bug we think about. Colonization rates can be as high as 93% depending on the region, age, population. And in the setting of community-acquired pneumonia in children, it's estimated to cause as much as 75% of cases. So it loves to cause pneumonia. That's why it's named like that. Haemophilus influenzae is another key colonizer of these tissues. Haemophilus influenza type B used to colonize 3 to 5% of children, but now that's decreased a lot post-vaccination. But non-typable H. flu is still very prevalent, estimated in 40 to 80% of children. So now here's the key point. H. flu is a gram-negative that is not covered by penicillin G and V, but is covered by ampicillin and amox. This is why we use it as first-line therapy for community-acquired pneumonia, acute otitis media, and acute sinusitis. It covers both strep pneumo and H. flu, but Pen G and V doesn't. Group A strep is another more rare potential pathogen. It commonly colonizes the pharynx in up to 10 to 15% of people. It's more rare pathogen in these infections. It tends to be more aggressive. So in acute otitis media, you might see perforation. In pneumonia, you might see an effusion, but it's also well covered by AMP and Amox. So these are the bugs we think of first. Of course, the game completely changes if your host has diseases in these tissues like cystic fibrosis or primary ciliary dyskinesia, or if they're immunodeficient, if their host has unique exposures to other pathogens, like if they have a prolonged hospital admission, or they have a tracheostomy tube that's colonized with gram-negatives like Klebsiella or Pseudomonas, if they just swallowed and choked on a bunch of lake water, if they live with a parrot, if their parents are rabbit skinners. This is why I emphasize the thinking process. What bugs might live there or be introduced there in this host? That's all some fun for another time. But in this regular old run-of-the-mill host, we think strep pneumo, H flu, maybe rarely group A strep as some of the first potential culprits, and AMP is a great first-line choice for these bugs. Now, this next point is very key. An important omission with ampicillin and amox is that it does not cover staph aureus. Drill that one into your brain. However, staph aureus is a very rare cause of community-acquired pneumonia, acute otitis media, or acute sinusitis. That's why we don't empirically cover it. In the setting of pneumonia, you might think about it if you see something like a lung abscess or a pneumatocele, since staph aureus is very pyogenic, or if you have some key risk factors like immune suppressed, chronic lung disease, less than 1 year old, or concurrent influenza infection, because there's an association with staph aureus bacterial superinfection in that context. And for sinusitis and acute otitis media, you don't think about it in the acute setting, but if someone had a subacute or chronic sinusitis, for example, then you might think about staph aureus. Oh, man. Oh, God. It's kind of what that last slide felt like, didn't it? A lot of information I'm throwing at you here, right at your face. So let's just take a breather. Let's get back in there. Another syndrome you've seen AMP used in is hospitalized pyelonephritis. You commonly see us use AMP with tobramycin. Why is that? Well, first, what bugs do we see causing urinary tract infections? It's the bacteria that come from the gut, contaminate the urinary tract, and then cause infection. And those bacteria are largely Enterobacteriaceae, which are a family of gut gram-negatives that include all of these bugs. But the most common ones that we see causing UTIs are E. coli, Proteus, and Klebsiella species. And ampicillin covers many strains of E. coli and Proteus, like we talked about. But not all strains, and not Klebsiella. Klebsiella is intrinsically resistant because it produces beta-lactamase. That makes it resistant to ampicillin. And so do actually some strains of E. coli and Proteus. We're going to talk about that in the next vodcast. But this is why we need to use tobramycin as well, to cover all the gut gram-negatives that AMP can't get. Enterococcus is a gram-positive from the gut that can cause UTI. Typically, this, though, is in someone who has an abnormal urinary tract or catheter. And Enterococcus is not to be confused with Enterobacter, which is actually a gram-negative. So we sometimes also see Enterococcus in endocarditis and also in central line-associated bloodstreams infections. And this next point is one of our important learning points. Ampicillin is the best option for Enterococcus, unless it has resistance. So there's two common species of Enterococcus. There's Faecalis and there's Faecium, and Faecium is more likely to be AMP resistant. So all of this taken together, ampicillin is used for hospitalized pyelonephritis to cover E. coli and Proteus, if they're susceptible, as well as Enterococcus, with tobramycin for gram-negatives. Hey, stay with me, one more. Okay, the last syndrome I want to talk about, neonatal meningitis, where you've seen us use ampicillin, tobramycin, and cefotaxime. So what bugs are we covering here? Okay, well, the key pathogens that we think of in neonatal meningitis, I like to remember with the acronym LEG: Listeria, E. coli, Group E strep. And so between tobramycin and cefotaxime, we actually have E. coli and Group E strep pretty well covered. The AMP is there more for the Listeria because, and this is your other learning point, ampicillin is your best antibiotic against Listeria. Listeria meningitis, we don't see much after 2 months of age, and that's why we don't see us using ampicillin for meningitis over this age group. Okay, those are all the syndromes I'm going to talk about today. The last thing I want you to know, key omissions that ampicillin and amox don't cover. So 1, they don't cover staph aureus, like we've talked about, and 2, they don't cover most gram-negatives, including many strains of E. coli, H. flu, and Proteus mirabilis, which are the very bugs I just told you ampicillin was designed to cover. Sorry to confuse you. We'll talk about why in the next podcast. So to summarize, here are your points for AMP and amox. 1, like Penicillin G and V, they cover streps well. 2, they have some extended gram-negative coverage over Pen G and V, including some strains of E. coli, H. flu, and Proteus mirabilis. 3, they do not cover most other gram-negatives. 4, they do not cover staph aureus. And 5, they are the best option for Enterococcus and Listeria. See you in the next one.